Buenos dias. Good morning. It's a pleasure to see very dear friends and again see a gathering of eminent scientists and clinicians here to our annual conference that focuses on personalized medicine. I've been fortunate enough to be a participant in the previous two conferences that were held in the United States last year in Las Vegas and the year before in Chicago. And these conferences have had the opportunity to allow continuity from one year to the next to bring together those who are assembled ideas and focused in the area of preventive and personalized medicine that, as we all know now, is really an important focus in patient care going forward this day and forward. I know in the United States this is an active area for both education in terms of how we train future physicians, but also as it relates to how we address worldwide issues. And organizations like the Centers for Disease Control in the United States, the World Health Organization, and our trace element institutes that we have around the world are trying to address this particular aspect of personalized medicine. So what I attempt to do this morning is a continuation, if you will, of previous presentations that are designed to review the concept of personalized medicine. I will mention briefly as an overview in terms of personalized medicine, but more importantly, I will shift the emphasis as it relates more to oncology in the practice of medicine as it relates to how we treat cancer patients. And I'll try to summarize some of the issues that I hope will be important for our discussions during the course of our meetings today. And basically, as the title says, is although there are new advances in our knowledge, actively right now there are hardworking, dedicated research scientists and clinicians working in laboratories all across the world, increasing our knowledge about diseases, both in terms of their pathology, their etiology, and also importantly, their therapeutics and how we treat them. The question then is, how is this new information, is it applicable to how patients are treated? Does it lead to better patient care? So that's the focus of what I hope to share with you this morning. So this is an overview that describes what personalized medicine attends to. And this basically is a somewhat simplistic, yet I think gives you the message that as personalized medicine, what it really is a definition. And the definition is the treatment in a particular patient of a specific diagnosis that's now going to be tailor-made to that individual's specific clinical condition. And that information that will target how that patient is treated will be based then on their genomics. So we were all familiar with the Human Genome Project that was very successful in identification of all of the genes in the human system. The thrust now in the past several years is to take that genetic information, understand how genes are activated and what that information upon activation relates then to any abnormality, and any abnormality then could lead to a specific disease pathology. So the personal genomics means that eventually, I think it's not a question of if, it's just a question of when, all of our patients, and perhaps the populations, will have their genetic profile determined. And then it'll be based upon what that information allows us then to better understand who would then be in a more predictive position to understand whether someone now is in a high-risk group for a particular pathology or clinical condition. At the same time, with the advent of personal genomics, we also then have pharmacogenomics. So pharmacogenomics is basically then taking that personalized genetic information and now tailor-making medicines best suited to now specifically treat that clinical condition that's now been identified through the genomics. Now, there's some revolutions that have been taking place with respect to pharmacogenomics. several of which I'll mention. I won't be able to go into very much detail as information is being gathered, but basically I can make the following statement, and that is, for all of the time that clinical trials were conducted, where by definition clinical trials is the testing whether or not a medication is going to have efficacy for the disease by which that medication has been developed, the personal genomic profile of the test subjects, that is, patients who were then enrolled in those clinical trials, was never factored into the results. And so we have then, over the course of time, basically as we are sitting here and I'm standing here, information that is not totally useful as it should be. And that's because the personal genomics of those individuals, when those clinical trials were conducted, was never taken into account. So does that mean all clinical trials would need to be redone? I don't think so. There isn't enough money to be able to do that. But certainly clinicians, administrators, health policy experts are grappling with this particular issue. And I'll give you another example. It's often stated that, and I think perhaps there's some unanimity in the room, we've all heard of, the fact that women live longer than men. Yes? Well, we now, Dr. Abdullah may have some argument with that. Maybe he is an example. But as in general, we now know there's a biological phenomenon to explain that, and that has to do with stem cells. Stem cells is something I'm very interested in. But basically, we now know that, yes, if we do believe that women live longer than men, it's because women have better stem cells than men. They're more effective. They are actually more physiologically effective, both in terms of the longevity and also their availability when it comes to regenerating tissues. So that is an aspect, again, related to clinical trials and personalized medicine that heretofore has been underappreciated. So we need to take into account those kinds of observations. So as I've said, personalized medicine is customized healthcare for the patient. So now, instead of dealing with patients as populations, we need to put our focus to the individuals. And the individual decisions, we as clinicians and those of us who deal as a variety of healthcare practitioners, we need to make accountability for the fact that our focus is for the patient and it's to the betterment of the patient. So as we now accumulate genomic data, both on our patients, then we're going to be able to best position ourselves as practitioners to best treat our patients, because the therapeutic approach will then be tailor-made, okay? And this is where the personal nature of the idea comes into play. Also, what's important, as I'll indicate as I go along in the presentation, it also puts responsibility on the patient himself or herself, because now the patient is going to be given information that he or she may then be able to utilize in terms of their own health status, in terms of what genetic information tells them that they're a higher risk for if they are then in a high-risk group. They may then be in a better position to alter their behavior. And behavior can be whether or not, for example, they've been a chronic smoker. They now need to know, because of a genetic predisposition, perhaps then they really should consider stop smoking or other trait or personal habit. And that also includes diet. So the focus in terms of personalized medicine is now understanding how our genes are best now in a position to help us understand our health care. So this is the goal of really now of government agencies and healthcare organizations, is how best to improve the overall healthcare status of our patients, taking into account this new revolution in genomic data, and make it now more applicable as practitioners need to understand that information and best utilize it in terms of how they strategize to treat their patients with a variety of conditions. And so we're vastly now accumulating lots of information that relates to what the genomic profile demonstrates in our patients. our goal then is to try to understand what of this growing list of information in terms of, for example, molecules that are present or are synthesized, released by cells in specific organs, is that of any diagnostic prevalence? Is it of any useful information? And how best then do we use that information to better the treatment of our patients? So the technology, as it points to in personalized medicine, has to do with the means by which then we identify these genetic changes, and how then do we utilize the information to translate into better patient care. So I'm going to focus the rest of my talk this morning as it relates to cancer. And cancer is because of all of the clinical specialties, it's the revolution within cancer with respect to the identifying genetic products that are the result of oncogenes, which is the genetic information that's now takes place in a cell that has now become transformed, leading to the development of a malignant disease. We have a growing list of molecules that are synthesized and released by cancer cells or precancerous state that gives us information that perhaps we would have a developing malignancy and the consequences thereof. And so the goal then, with respect to this ever-increasing list of biomarkers, that is, these are the products of the genomes in cells in individuals that then give rise to these substances that could lead to the development and prevalence of cancer. How useful are they for practitioners to be able to help diagnose, treat, and also to serve as prognostic? In other words, how effective has the treatment been in terms of the continued synthesis of these biomarkers that are the result of oncogenes? Does it relate to better patient care for cancer patients? So most experts, as it says, they believe that the profiling, that is our understanding and knowing that these genetic markers exist, the issues are what we're facing. And this is basically just because there may be an expression of a molecule. Does it actually have prognostic significance? Does it actually lead to a biomarker saying that an individual would be at a higher risk? And also, what does it do in terms of the general public? So we as healthcare practitioners, we must have a responsibility to best understand that information, but also to be the communicator of that information, not just to patients, but also to the general public. When they read news stories and they become aware of such substances or techniques or technologies when they get into the public media. But it also gives a sense in terms of individuals and patients and how they react. In other words, if a patient finds or is told that he or she may be positive for something that's been identified as a high risk, what do they do about it? Do they worry about it? Do they become anxious? Do they panic? Or do they become proactive in terms of dealing with what could potentially be a major healthcare issue for themselves and how their loved ones deal with that? So these are all conditions that we need to be aware of. Some of them become quite public, especially in individuals who are sort of in the spotlight. And I'll give an indication and an example of that in terms of how it helps the general population in terms of self-awareness with respect to these kinds of factors. So the basic questions are, what's the value of genomic profiling and genetic sequencing? So yes, this is a technology that's available. Initially, it was a very expensive procedure to have done, costing in the thousands of dollars. That's not a useful level of financing in terms of general populace being able to have the monetary means of being able to have that information. As the technology continues to develop, becomes more sophisticated, at the same time, hopefully become more cost effective in terms of the overall cost. The other limitation, if you will, is what happens to that information. So in, I think, countries that are under the luxury of a generalized healthcare system, that maybe it isn't so much of a problem. But still, in the United States, it would be a problem, since that information could conceivably be used by insurance companies to either deny access to healthcare because those patients now, if they are demonstrated to have a risk factor leading to a malignant disease, then perhaps they would lose their healthcare insurance. But that's a problem we still, as a country, have to face. But overall, the issue then is how best to make this new revolution available to the wider general population and also to the wide masses that would be in the clinic. And so for cancer, the work and effort is focused to make the genetic information that comes from studies that is an associated high risk between the presence of a biomarker as a product of an oncogene with then a particular malignant disease. Does that help the oncologist and the associated team better treat that patient? So the question then becomes is how, when there are variations, and again, these are going to be due to a variety of risk factors and accumulation of knowledge, to best identify what genetic information is most useful, what is less useful in terms of going forward in the treatment, and certainly predisposition of any particular sets of clinical conditions leading to specific types of cancers. And so as a category, then conditions such as bone marrow failure, congenital neutropenia, and hemoglobinopathies are areas in terms of blood cell dyscrasias that these oncogene markers are showing quite promise in helping and assisting clinicians being able to further advance the knowledge. So the question still is to be determined is what's the impact of these discoveries on patients and how that helps or hurts patients in terms of the care that he or she will need to receive. What strategies are being considered now to help address this question for practitioners? So in the United States, through the federal government's program, through the National Institutes of Health, they are at least earmarking monies to best address this question, to try to understand and better understand the relationships between these genetic observations and genetic molecules as a result of the human genome, and make them more available so it's not such that it's personalized medicine, also now that it actually becomes precision medicine, being able then to hopefully identify these changes that take place and then develop more effective prevention and treatment strategies. And the goal then is when that information is available, it really shifts the responsibility then to the patient that he or she either needs to alter their lifestyle, alter their habits, whether it has to do with diet, lifestyle, as I mentioned, if they're smokers, maybe minimizing or eliminating smoking, those factors that have been well documented as being high risk. The other condition in terms of screening volunteers, that is normal, what's the normal sort of database in the population as it relates to incidences and diseases as a public health issue. So for the agency within the United States federal government of the NIH, which is the National Cancer Institute, they're earmarking $70 million the fiscal year 2016 to try to address this question as it relates to how does this genomic data and the information that's generated as a result of the Human Genome Project relate to specific cancers. And hopefully that information will help, as it's disseminated through clinical practice, best identify patients that are high risk and then identify strategies that those patients can do as they go forward. Another tool that will sort of coordinate that information with respect to making it more uniform is what we refer to as the Universal Electronic Medical Record, which is something that is under development in the United States to try to make all patient data as he or she would be then, whether it's through their intervention in a clinic or in hospital is something known as eMERGE, which is the electronic medical record and genomics. So this will be the electronic mechanism by which this data will be uploaded and then could be shared by clinicians, healthcare practitioners, public health individuals to best understand the relationship with this emerging data and how it then affects patients both in terms of their high risk as well as their ability then to be responsive if they do show a high preponderance or risk for a particular type of cancer. So initially, the project in terms of this electronic medical database is then to try to screen as many normal volunteers, normal individuals, to basically here is the goal, is what's the baseline in a general population. So the focus then of the NCI here is then to screen 100 different genes with respect to their input and effect in promoting and predicting high-risk relationships to the development of cancer. So this hopefully will be information that we as public health officials, as the public health community, will then know what's the incidence in the general population that could then be influenced if an individual then also engages in a high-risk behavior. So the advantages of this genetic testing hopefully will make genetic profiling a more frequent tool. Again, the goal that it would improve patient care. The issue is does this mean that this is the only or is it the best course of action? We're not yet there, and it will take some time to best address this question, because just because one identifies the presence or the likelihood that an oncogene or a product of an oncogene is indeed present, it then is how prevalent it is. Is it widespread or is it only localized as a healthcare strategy going forward? So it may not necessarily be that just because a molecule has been identified that it needs to actually get into the clinical arena of something that needs to be tested. An example of that could be PSA, prostate-specific antigen. Once thought to be a predictive marker for prostate cancer in men, we now know that the information is not very helpful. So a more specific example, certainly in the case of women's health, is the relationship with the expression of the BCR BRCA1, BRCA2 gene as it relates to human breast cancer. And the data shows, as the NCI has collected, that women who inherit the BRCA1, BRCA2 gene are in a high-risk group for developing some form of breast and or ovarian cancer during the course of their lifetime, 55 to 65% by the age of 70. So the well-publicized person in this category was the actress Angelina Jolie, who had family history of a mother and grandmother, I think also an aunt, succumbed to ovarian breast cancer, and she had herself tested. She was positive for BRCA1, BRCA2, and she went ahead and had a double mastectomy performed as a preventive health measure. So that's the example. Some feel that she was very courageous in doing this, to making this as a public health awareness. And so these are some of the circumstances how this information can be made available and also be an improvement of public health. Another example is the disease hemochromatosis, where we're able to identify patients who have this specific gene that allows them to absorb too much iron, and the too much iron transforms the liver into hepatocarcinoma and or cirrhosis. So this information then can help used as a screen in terms of identifying patients who would be a high-risk group because they have an abnormality in their iron metabolism. So these are examples of where clinicians and oncologists, public health, can validate the effectiveness of the genetic variants and how that affects patient care going forward. Other diseases are not so easy. So I put this in just to give you a comparison. With respect to multifactorial in terms of disease etiology and pathology, diseases like diabetes and cardiovascular diseases may be much more difficult to try to link a specific genetic aberration based on the fact that the consequences and the contributing factors for these diseases is much more difficult. Not to say it cannot be done, but it may be requiring more studies, more clinical evaluations to determine whether the genomic profile related to these conditions would be helpful, but time will tell. So the complexities are still problematic, especially if they're multifactorial, rather than that would be a single therapeutic target. It appears that perhaps in cancer it leans more to the single oncogene or other focused transformations that pinpoint cancers versus the other two examples. And hopefully that will then lead to better strategy in patient care because specific therapeutics can be designed. So as a growing clinical practice, as oncologists, they now will have in their patients, if a patient is diagnosed with a particular type of cancer, usually as a byproduct of the biopsy, the tumor tissue is now routinely screened for the presence of specific genetic makeup of that tumor, and that genetic information now specific for the tumor, specifically from that patient, is now tested in terms of what specific cancer chemotherapeutic drugs are most sensitive to those tumor tissues, and or strategies for immunotherapy, where immunotherapy is utilizing the immune system to generate specific antibodies that are targeted that specific cancer. Where's the private sector in this scheme? And right now, or at least the private sector's role is that they are serving as the entity that performs the genetic testing. Here again, problematic with anything that starts from the ground up. We need to make sure that all companies that are in this business are competent for what they do and the information that they produce, and also eventually that it's cost effective. So yes, these were expensive procedures in terms of the genomic profiling. Hopefully that cost will continue to decrease to make it more affordable. And the information that's generated, certainly we don't want false positives, and we want to be able to make sure that the information that's generated is the most effective, because it's still supposed to be about the patient. Perhaps in terms of a strategy, for those patients who traditionally undergo standard cancer therapeutic regimens of chemotherapy and radiation therapy, if they fail what's described as conventional therapy, then this approach may be more effective for those patients because, again, it targets the specific nature of their oncological disease based on their specific genomics. So that could be a benefit to those patients who initially fail conventional therapeutic rationale. One issue is, with respect to the private companies, is when they deal and market directly to the patient. So we have to be careful that their marketing is of sound science, and also the interpretation of how the test is being performed, and also the procedure by which the information needs to be evaluated. So the rationale that the company then markets directly to the patient and without the intervention of the healthcare professional in between can be problematic, only because of the nature of the general populace fully understanding what it is they're being asked to do, and also what is the emotional impact by that patient when he or she does that home in-base test and turns up a positive result. So genetic counseling can be important. So that's something that we always need to keep in the back of our minds. So right now, the genetic testing, the research is continuing. There are certain studies that have been published in the New England Journal of Medicine that are looking at the association between specific genes and a variety of myeloid and lymphoid cancers. And their results show that there are populations, especially with respect to age, may be in a higher risk category. So as these studies continue to be performed and the results are released, helps us moving forward in our understanding. Also, we may be able to not just focus on biopsied material, we may be able to take samples from peripheral blood and be able to use those cells as our test product in order to be able to determine these genetic changes. So another study reported here in New England Journal of Medicine showed that there was a propensity for the expression of some somatic mutations using peripheral blood, indicating an increased risk of certain types of somatic cancer, blood cancers, myelodysplastic syndromes as a function of age. Yes, we know this in general. As we increase in age, aging is associated with a higher risk group, but it doesn't always mean that it's due to a genetic change or a genetic malfunction. So we need to make sure we understand that relationship. We also need to make sure that someone who is identified is indeed then in a high-risk group, and we need then to look at what we call genetic polymorphisms to make sure that those changes represent indeed clinical change. And also, with respect to the example here, once that information is made available, is there altered lifestyle and other changes that can be implied by that information to those patients? So here is the comparison. So with respect to patients who are high risk for diabetes and heart disease, they know we can intervene by giving them concrete and sound information on the role and importance of exercise, role and importance of dietary change. May not be so easy if we're dealing with cancers. So in general, better lifestyles obviously lead to better health outcomes. We need to make sure that whether we're doing pre-testing or post-testing, there is sufficient counseling so that all patients understand the ramifications of this information and what then would be the recommendations. So the goal then is not just to identify what genetic alteration takes place, what's the significance of that genetic alteration? What does it mean clinically in terms of etiology, pathology, and also therapeutic strategy going forward? It can be a complicated process, but I think as we continue and we understand and fully understand the changes in the human genome, whether they're intrinsic or extrinsic to the nature of what is the causative factor for those genetic mutations, will help us understand how those changes increase the risk in our patients and also increase our therapeutic strategies. Again, the goal will be is to establish a baseline with respect to what is the general population status, then look at the positive and negative factors, and then we also need to make sure we never be removed from the ethics of genetic testing, because again, that information needs to be held privileged. It needs to be thought through very carefully in terms of how that information is used. Yes, prenatal screenings would be also. So the genetic roadmap, what's ahead? So we basically have only scratched the surface in understanding the role of genetics in the human genome. And again, the goal would be how to use this information to best develop and prepare for clinical use treatment strategies that helps not only influence the incidence of these diseases, but also the outcomes in any patient who unfortunately succumbs. So again, I come back to this figure that, again, it's a cycle. We're, again, gaining in our knowledge of personal genomics. We then want to focus and pinpoint and strategize through personal genomics, the pharmacogenomics that puts in place a better targeted therapy so that our delivery of medicine to help the health status of our patients is indeed much improved. So here are some references. I'd be happy to provide them. And I thank you for your attention. Any questions? Yes.
I always struggle to use the correlational studies. Thank you. I think actually don't need this, but anyway, I always struggle to use the correlational studies with the experimental studies. One example is a paper that came, I think it was in Nature, talk about the sweetness and obesity and insulin resistance. In this paper, if I can remember well, they mention about use the sweetness experimentally, showing that the rats can show some insulin resistance, but did not show obesity. But when they saw the correlation studies for humans, it was positive. It means the sweetness show positive correlation with the obesity. So how can we interpret this? I mean, always is sort of confusing, always in my mind as an experimental researcher, I need some experimental data.
Yes, I agree. Experimental data is important, and I too am an in vivo proponent in terms of animal studies are, I think, important to address questions in terms of how would a particular therapy, medicine, drug, chemical, interact, knowing full well that even though it's in a test animal, there is somewhat significant physiology between that animal model and humans. Doesn't always mean that it's perfect. So it's always going to be a matter of interpretation of that data. So that's almost is always a question that one has to raise when one looks at an in vivo study, as often is what then is the relevance in terms of humans. So I think we're all aware of the fact that just because an animal model is used, and more often than not, it's the goal is basically to understand whether potential therapy has toxic effects, as well as whether or not there are therapeutic effects. So, no animal model is perfect, and certainly that's one of the, I think, concerns about in vivo animal modeling systems. So one just has to be aware of those pitfalls when one looks at animal modeling studies and when one looks at the data to try to make, is there always going to be a clear association of what is demonstrated in the animal model that what is seen clinically is not necessarily indeed the case. So that's something that we all take into consideration whenever we're doing in vivo animal modeling. It helps, certainly in the case of cancer, it helps us quite immensely because in the case of cancer, we argumentatively go through a series of steps because if a molecule, a chemical, is proposed to be a potential cancer chemotherapeutic agent, well, the very first thing we do is we take that molecule, that chemical, and we put it in culture in an in vitro system to see whether or not does the drug kill the cancer cell. Well, if the answer to that question is yes, then that leads us now into the next step of studies, which will be then to test it in an in vivo model system to see is the dose or the concentration that it was effective in vitro, does it work in vivo? So if it's shown that it can work in vivo, but yet maybe concentrations that are too toxic, they'll never see the light of day, so it doesn't go forward in development. So those are some of the pitfalls, but some of the the process that we go through when we're looking at drug development, and especially the therapeutic benefit of any molecule, its efficacy and its toxicity profile. Yes.
Nice listening to your talk. Vince, I have a special question. In my clinical practice, I see about 15 to 20 patients every day, and 75% of them are okay, they are healthy people, but they go on reading all this rubbish that's coming on internet and
Yes.
media, and they all have those sicknesses, which they say. one guy come and said that you must take the PSA because I have prostate cancer. Now, this is the biggest issue we have, how to deal with this kind of patient, what to tell them. Look, you're a healthy man, healthy woman, there's nothing wrong with you. But no, it is written very clearly that, if you have PSA 3.1, then you're definitely going to have cancer. Now, how do we deal with that kind of mass information that is coming at a large scale, including this genetic testing, as you mentioned?
Yes, you raise a very, very good and an important point because, yes, the internet has been, I think, a wonderful invention, if we put it in that category, but what it also has done is allowed individuals, like your patients, the opportunity to interact via the internet and get access to information without ever even contacting you, wanting your personal and professional opinion. So yes, this information is available to them, and many do now seek the internet, especially when they have specific symptoms. Is this something that requires me now to seek medical attention? They first look it up on the internet. WebMD is a very popular site. So yes, this is a growing problem because of the information that's made available. And it's also, I think, of question in terms of the pharmaceutical companies, because the pharmaceutical companies are also taking advantage of the informational highway, and they're now, and we're inundated in the United States with commercials because most of our television broadcasts by television. Pharmaceutical companies advertising their specific medicines directly to you, the patient. You have that symptom, you have that ailment. Here, this is what we intend for you to do. Here's the medicine. Go tell your physician to prescribe it for you. It's a huge problem. I mean, if I always use this example to my students. If you came from outer space and you came to Earth, and let's say you landed in the United States and you watched our television, you would think, without question, the major health concern, number one, is erectile dysfunction. Because the pharmaceutical companies are only looking to promote those medications that for them are the highest profit. It's a sin. They should all be arrested and thrown in jail, but that's another issue for another day. But you raise a very important point, because where do we put put it back in the box to help control how patients take this information? And then some cases, I wouldn't be surprised, they demand that they'd be tested. Yes.
Along the same lines, I have a question of ignorance. You mentioned the consumer genomics companies. I have to admit I don't know much about them. What exactly information does the person paying for their genome get back? They get a list of things that say you have a 10%, this particular gene gives you 10% higher chance to have type 2 diabetes, and this particular gene. Do they sit down with a professional who explains to them what those things mean, or is just that they get a computer printout?
They're just given the information verbatim, so to speak. Then if they are of a self-awareness, they will then either bring that information to the attention of their own healthcare provider to say, this is the results of the testing that I had done. What does it mean? Is this something that I need to be concerned about? So yes, in terms of the information being made available, it can be important. If it's information that is directed by the healthcare provider because their patient is either showing symptoms and or may already have a diagnosis, so it's not, as I indicated, not unusual now for cancer patients, once an individual is diagnosed, once their tumor has been biopsied, usually the oncologist will take a sample and have a genomic analysis done of that specific tumor tissue to identify. But in terms of the general populace, it's out, it's been released and it's out there, but no specific guidelines yet on how the companies are basically being asked to conform to any health status or policy. Yeah. any company, like any company, is in, for business. So they're wanting to make sure that they get the return on their investment. It's something we need to pay attention to going forward. Any other questions? Thank you for your attention.